Burning, inturation, there was no decreased appetite, loss of weight, fatigue, or night sweats. Past history was not significant, and antenatal and birth history was uneventful. Developmentally, child has attained all milestones at appropriate age, and child studying first handed with good scholastic performance. Child is immunized till 5 years of age according to national immunization schedule, and family history is not significant. So, to summarize, a 9-year-old male child presented with an incidentally noticed abdominal swelling in left hypochondrium and lumbar region 4 days back, associated with minimal pain while playing and a lying down position, and with an episode of vomiting with no history of trauma, bleeding, tendencies, loss of appetite, loss of weight, or fever. Coming to general examination, child was conscious, alert, oriented to timeless person and was attendized. General to examination was normal. Vitals were within normal limits for his age. Anthropometry was normal. Systemic examination on inspection, the shape of the abdomen was flat, abdominal thoracic type of respiration was present. There was localized distinction present in the left hypochondrial and lumbar region, not within the midline. Size of approximately 8 cross 10 centimeters, which was more appreciable in supine position, fully respiration, and does not become prominent with head rising rest. Skin over the abdomen appears moderate. There was no ulceration or scars on the abdomen. Umbilicus position and not displaced. There were no visible superficial veins, visible pulsation or peristalsis. Inguinal region was normal and genitals were normal. On confirmation, abdomen was soft. There was localized swelling in left hypochondrial and left lumbar region, which was not crossed to the midline. Swelling was non-fatal.
കേൾക്കുന്നില്ലേ മാഡം? കേൾക്കവില്ല. அதெல்லாம் ஏசி கிளாஸ் உட்காந்துருக்காங்க. ಕ್ಲಿಯರ್ ಆವಿಲ್ಲ. ரேவதி 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 ஃபுல் இப்போ நான் இல்ல செட்டிநாடு நம்ம பிரசன்டேஷனுக்கு மியூட் எங்க
A 9-year-old male child presented with an incidentally noticed abdominal swelling in left hypochondrium and lumbar region 4 days back, associated with minimal pain while playing in a lying down position, and with an episode of vomiting with no history of trauma, bleeding tendency, loss of appetite, loss of weight, or fever. General examination, child was conscious, alert, oriented, and exercise. Head to examination was normal, and the vitals were within normal limits for his age. Anthropometry was normal. Systemic examination on inspection, shape of the abdomen was flat, abdominal thoracic type of respiration was present. There was localized distinction present in the left hypochondrial and lumbar region, which was not crossing the midline. Size of approximately 8 cross 10 centimeters, which was more appreciable in supine position, which poorly moves with respiration and does not become prominent with head rising rest. Skin over the abdomen appears normal. There was no ulceration or scars on the abdomen. Umbilicus was central. It was inverted and not displaced. No visible superficial veins, visible pulsation or peristalsis was seen. Inguinal region and genitals were normal. On palpation, abdomen is soft and the localized swelling in left hypochondriac and left lumbar region, which was not possible trend. Non-tender, hard in consistency, smooth surface with ill-defined borders, approximate size of 8 cross 10 centimeters, and not palpable. Fixed and swelling was not provided. There was no ascites and no hepatomegaly. No other masses were palpable. On percussion, there was dull knot over the mass and tympanic knot in the surroundings. On auscultation, vowel sounds were heard and there was no bruit. Other systemic examination was normal. So the differential diagnosis is an abdominal mass which is probably a Wilms tumor, neuroblastoma, leukemia, lymphoma, or polycystic kidney disease, hydronephrosis, or thalassemia. Investigation revealed the moderate anemia, HB of 9 grams, peripheral smear was normal, there was no rash cells, LFT was normal, RFT and urine protein were normal, and serum amylase ligase were within normal limits. Retic count was 0.2, TCT was negative. CRP was non-reactive, ESR and NAH were normal, and PAN was negative. Radiological X-ray done revealed intra-abdominal homogeneous mass in the left hypochondrium and lumbar region, which was displacing the bowel movements. USG abdomen revealed well-defined heterogeneous lobulated, predominantly solid lesion, which was measuring 9.4 cross 8.3 centimeters, with few cystic spaces and multiple echogenic calcific foci. Seen in the left upper quadrant, closely abutting the left kidney and lower pole of spleen with intercalcific gravity. On color of spleen and left kidney margins are clearly separate from the lesion. There were few enlarged paraortic nodes, measuring 2.1 centimeter in short axis diameter with loss of fatty edge. On CECT abdomen, there will large heterogeneously enhancing long soft tissue density lesion measuring 11 cross 8.6 cross 7 centimeter with few necrotic areas and few tiny calcification noted in left hypochondrium, abutting the left kidney posteriorly and spleen and pancreas superiorly. There were cleaning vessels noted, and there were two enlarged lymph nodes noted in pre and para-aortic region, largest one measuring 3.7 cross 2.7 centimeters. There was minimal fluid in the lymph. Oncology opinion was obtained, and parents were counseled regarding the likelihood of malignancy, probably neuroblastoma, and suggested to CT biopsy of mitochondrial mass and NYPG scan. PET-CT scan done showed hypermetabolic malignant mass lesion in left suprarenal region and hypermetabolic metastatic paraortic lymph nodes. Non-FDG with bilateral lung nodules, which was likely metastasis. There was no evidence of metabolically active disease elsewhere. And biopsy before that showed malignant downside tumor, possibly neuroblastoma. Bone marrow accident report showed cellular marrow with fine image. Immune histochemistry showed positive for CD56 synaptophysin against 100. So we came to the diagnosis of neuroblastoma stage M because of metastasis and pre-treatment risk to be high. Neuroblastoma is an embryonal cell of the structure of the peripheral sympathetic nervous system of dorsal spinal nerve, spinal ganglion, and epithelial medulla. It's the most common extracranial solid tumor in children. The median age of diagnosis is 18 months, and males are more commonly affected. Abdomen is the most common site, and it's a small round blue cell tumors with variable degrees of neural differentiation. Homer right tumorosis are found in some cases. As you can see in this picture, cancer cells surrounding the stroma. Phytogenesis, in most of the cases, the etiology remains unknown. Genes associated with risk of developing neuroblastoma are present in Baker-Friedman syndrome, loss of heterozygosity of 1p11q at 40q, gain of 17q, MYCN amplification, loss of function in ADRX and TRP gene, and familial neuroblastoma is very rare, only occurring in 1 to 2% of all cases. It is linked to the germline vein of function pathogenic variants in FOX2B, BARD1, and ALK genes. Few syndromes are predisposing to neuroblastoma, neuroblastopathy syndrome, Becker-Friedman syndrome, Costello syndrome, familial pheochromocytoma, Fanconi anemia, levofibromatosis type 1, Noonan syndrome, and Turner syndrome. Clinical features can be because of the low-rise disease can manifest as an asymptomatic abdominal mass. Abdominal mass will produce mass effect leading to bowel obstruction and cord compensation. There can be increased sweating and hypertension in tumors producing catecholamines. Secondary diarrhea can be present due to production of isoactive intestinal peptide. Children with extensive tumor can also experience tumor lysis syndrome and disseminated intravascular coagulation. There can be metastatic disease causing fever, bone pain, cytopenia, failure to serve orbital prophylaxis, and periorbital epicosis. The most common site of metastasis are the regional lymph nodes, regional and distal lymph nodes, followed by long bones and skull, bone marrow, liver, lungs, and brain. Pepper syndrome, Horner syndrome, Hutchinson syndrome, oxyclonus, myoclonus, ataxia syndrome, Turner-Morrison syndrome, neuroblastoma syndrome, and the syndromes associated with neuroblastoma. Investigations, CBC with cerebrosphere, LFT, RFT, urine vanillin mandelic acid, homoandelic acid, which are the catecholamines metabolic, the regulated in most of the cases. Imaging required are X-ray, which may show the mass calcification, CT. MRKG scan to define the extent of disease. PET-CT or MRI is rather useful method to define the extent of disease. And biopsy and immunohistochemistry for the diagnosis and staging the disease. Bone marrow biopsy to evaluate for the bone marrow disease. So to stage neuroblastoma, international neuroblastoma staging is used. Which divide N1, N2, M and M1. N1 is the localized tumor which does not involve the vital structure and there are no image-defined risk factors. In L2, there is local regional tumor with image-defined risk factors. Image-defined risk factors are like when the tumor is encasing or displacing or the tumor is infiltrating the surrounding structures. MS distant metastatic disease, except MS is metastatic disease in infants less than 18 months, limited to skin, liver, and bone marrow. These are the image-defined risk factors. So in our child, there is likely metastasis to lung to stage N, and the age is more than 18 years. So he comes under the high risk pre-treatment group. The treatment options are the low risk and intermediate risk and survival rate is more than 90%, and high risk only 25 to 35% survival rate. For low risk group, surgery is required to resect the tumor, followed by chemotherapy or radiotherapy only if there is local recurrence. Intermediate risk group, surgery is done to remove the tumor, and chemotherapy with cisplatin, cyclophosphamide, etoposide, doxorubicin over 7 months, and radiotherapy only for those with incomplete response to chemotherapy. For high risk groups, induction chemotherapy followed by dissection of tumor. High-risk chemotherapy with autologous stem cell residue plus differentiating agent against retinoic acid plus dinutuximab and focal radiation.
Thank you, Dr. Kiran. This goes to prove that even though common things are common, we still encounter a lot of uncommon things. Before we open for questions.
Ma'am, it was a good presentation.
Yes,
Ma'am, vanillin mandelic acid was done, ma'am, for this child. Actually, we have some connectivity issues.
Sir, it was not done for this child itself.
Okay, ma'am. Okay.
Because
Actually,
the child went to a tertiary center from here, sir, because to the hometown the child has been referred. They wanted to go to the hometown. So there they only done the biopsy, sir, and immunohistochemistry. So VMA was not done for the child.
okay, okay. Long back, when I was in the early service, there was a case of like presenting with similar abdominal mass actually. So there in the surgeons used to any mass they open up actually. So surgeons opened up the mass and then there was a real problem with the chemotherapy and then healing of the wound. So I think what you did was the staging is important. So doing the biopsy before opening up so that chemotherapy, if needed, can be given first rather than going surgery straight away. So that child, we had tough time when surgery was done and then biopsy was proven as neuroblastoma, and we were not able to give chemotherapy, and it was a tough time actually. So the well managed. Good, thank you.
Thank you, sir. This child currently on third cycle of chemotherapy, but he is in advanced stage so that the mass didn't regress. It is in the same site, sir. So they are not planning for surgery as of now for this child for resection.
Okay, okay. Thank you, thank you.
Thank you. So moving on to the next presentation. I invite Dr. Roshni from Balaji, Sri Balaji Medical College. The topic is recursive clinical syndrome. Over to Dr. Roshni.
Good morning, respected sirs and ma'ams. Please, am I audible?
Hello. Yeah, please continue.
Hello.
Yeah. You can just switch to
Am I audible,
line.
ma'am?
You're audible. You can start your presentation after
Press.
changing it over to a slideshow.
Okay. So my presentation is called a pressing clinical syndrome on behalf of the Department of Pediatric, Sri Balaji Medical College Hospital. So moving on to the presentation. We had a 13-year-old boy whose informant was the mother, whose reliability was good, was brought to the emergency room with complaints of fever for 2 days, followed by complaints of puffiness of face, followed by swelling of feet and abdominal distension over the next 2 days, as noticed by the mother. Complaints of 4 episodes of seizures of right, upper, and lower limbs since 6 a.m. on day 7 of illness, for which the child was brought to the hospital. Apparently, while child a week ago developed complaints of fever for 2 days, which was low grade, intermittent relief temporarily on antipyretics. Child was active during interfebrile period. There was complaints of puffiness of the face, swelling of feet, and distension of abdomen over the next 2 days, along with passage of cola-colored urine, noticed by the mother, not associated with any pain or burning micturition, dysuria, or rash. Child was taken to a nearby clinic where the initial investigations were done. Mother was told that child had a renal issue and was treated for 5 days with oral furosemide and corticosteroids on an OPD basis. Following this, the distension of the abdomen, face, and feet partially reduced. However, child continued to pass cola-colored urine. And on day 6 of illness, child developed complaints of frontal headache, which was continuous without aggravating or relieving factors, and not associated with nausea, vomiting, photophobia, or a tinnitus, dizziness, or visual disturbances. The following morning, around 6 a.m., the child developed complaints of 4 episodes of seizures of right, upper, and lower limb. And for these complaints, the child was brought to the hospital to the emergency room. The seizures were jerky movements of right side, upper, and lower limbs lasting for less than a minute each, associated with loss of consciousness. However, the episodes were self-limiting and the child regained consciousness in between the episodes, and it wasn't associated with any passage of urine stools. So the first episode of seizures began at 6 a.m. and there were 3 more episodes over the next 2 hours. There was no history of sore throat or cough, no history of fever with rash or joint pain, no history of abdominal pain, flank pain, or rash over the limbs, no history of reduced urine output or frothy urine, no history of vomiting, neck pain, abnormal behavior, or visual disturbances. There was no history of trauma, recent blood transfusion, or drug take.
The participant can imagine yourself
Without even thought about
Um,
about number one day.
moving on to the stabilization, the
And
emergency
that
room.
Roshni, your
The
slide is
child
not moving.
presented with in a state in
Your
state.
slide is not moving.
Sorry.
Roshni,
Your slide is not moving.
your slides are not moving.
Okay.
Can you once again
Please
share the
excuse
next
me.
screen?
Let me just check. Yes. Still in the same set. Okay. Are the slides visible now?
No, it's not visible.
No.
Now it's visible. Yeah. Thank you.
Okay. So the no history of sore throat, cough, no history of fever with rash or joint pain, and no history of abdominal pain, flank pain, rash of the limbs, no history of reduced urine output, frothy urine, no history of vomiting, rash, neck pain, or abnormal behavior, no history of visual disturbances or trauma. The child was stabilized with the bolus doses of injection of anti-epileptics and diuretics with furosemide.
Roshni, your slides are
And
not
we
visible.
found on a primary assessment that the child was hypertensive with a systolic blood pressure of 210 and
Roshni,
diastolic by 110. It was in the above the 99th centile for age for the child.
Dr. Roshni, your slides are not visible.
Sir?
Your slides are not visible.
Sorry?
Can you do the slide share now?
Sir, it is on slide share.
No, I think so. You're out of slide share now.
So I'm so sorry. Let me just try that again.
And now it's visible.
So we stabilize the child in the ER with the status of anti-epileptics according to the status epilepticus protocol and intravenous dose of furosemide. After which we shifted the child to the PICU. Child progressed and had another episode of seizure along with transient drowsiness. Child was again treated with IV anti-epileptics and we started the child on a loading of injection levetiracetam. We continued the furosemide diuretics and we also started the child on oral antihypertensive, calcium channel blocker nifedipine in order to maintain a continuous or controlled hypertension. So our aim was to reduce the blood pressure over the next 48 hours below the 90th centile. When we took a detailed sample history, we found that the child had history of skin lesions over bilateral arms and legs treated with oral and topical antibiotics around 3 weeks ago. There were no similar complaints of seizures or hypertensive episodes in the past. Antenatal birth and postnatal history was uneventful. Developmentally, the child was appropriate and the child was also immunized for age. Family history was not significant for consanguineous marriage or any similar illness family. There was no significant contact or allergy history. Moving on to the general examination. Post stabilization, we found the child to be drowsy but arousable with a GPS of 12 by 15. The child was efebrile, adequately hydrated, and the perfusion was adequate. Pallor was noted with facial puffiness and bilateral pedal edema. There was no cyanosis, clubbing, or lymphadenopathy. Head-to-toe examination revealed healed impetiginous lesions over both upper and lower limbs. The anthropometry of the child was within normal for the age and sex. Central nervous system examination revealed slides. The central nervous system examination revealed that the pupils were equal and reactant to light. The cranial nerve examination was normal. Motor and sensory system was normal with no cerebellar or meningeal signs. Skull and spine was normal. Ophthalmologic examination evaluation no signs of raised ICP or papillary edema. No scars, signs, veins. The flanks were free. On palpation of the abdomen, we found that the abdomen was soft, non-tender, without any tanglements or megaly. Was present, and on auscultation, bowel sounds were heard. External genitalia was normal, and other systems were found to be normal. Outside investigations done by the child, the record brought to us by parents revealed the slide. Just a minute. Outside investigations revealed a urine protein of 2,300 milligrams per deciliter, creatinine of 426.43 milligram per deciliter. ASO titers were bodily elevated at 202 international units per ml. C3 was found to be low, along with the mild reduction in C4 as well. Other investigations were within normal limits. When we repeated the investigations, we found a similar trend with hypocomplementary anemia and borderline elevated AS. Urinalysis revealed albumin plus 3 plus in the urine with plenty of RBCs, which subsequently reduced and normalized over the course of hospital stay with treatment. Just waiting for the slide to shift. Yeah, so this was a gross hematuria with dark reddish brown urine. Displayed on this slide. We proceeded to do an MRI of the brain, which revealed diffusion restriction in the hyperparietal and occipital cortexes. The slide is just about to change. Diffusion restriction in the hyperparietal and occipital cortexes, symptomatic edema in bilateral, parietal, and occipital regions. T2 flare hyperintensities were also noticed at the junction of the body and the corpus of the corpus callosum. Ultrasound of the abdomen revealed a normal study, and echocardiography was also normal. Yes, so that's the MRI image. Diffusion restriction in high parietal and occipital cortex is indicated by the blue arrow. And moving on to the USG abdomen and echocardiography findings, they were found to be normal. The slides are not changing. Trying.
Roshni, are you there? Hello. Now, Roshni, your voice is not audible. Your slides are not
Just
moving.
taking slowly. Please, apologies for the inconvenience. So, the diagnosis. So, in the clinical picture of acute glomerulonephritis, along with low serum C3 levels in the presence of pyodermal skin infection with evidence of antecedent streptococcus infection and elevated ASO titers, take ultrasensorial seizures and symmetrical activity potential acute glomerulonephritis.
Roshni, your internet connection, I think so. You're out, I think so. So you're not there. So, can we not discuss the question? Dr. Roshni, are you there?
I think she has some problems with her neck. However, since we have reached, I think, almost she has completed the diagnosis. While we coming over the case that what we used to limit to hypertensive encephalopathy, with the universal availability of MRA, we have reached, we have a new term, press, but it's not new anymore. Congratulations to their team for a good job done and choosing a very creative title, Pressing Clinical Syndrome. I don't think she will she be available to answer any questions if anybody has any questions?
Ma'am, sorry for the interruption, ma'am. We are from Sri Balaji Medical College. Can you just spare us a moment, ma'am? There is some technical issue from our end. We are just trying it to reconnect it.
No,
Just spare us a couple of minutes, ma'am. We'll be reconnecting it soon. The presenter is reconnecting, ma'am. Just spare us 2 minutes of time. Sorry for the interruption. Sorry.
While we are trying to reconnect, shall we move on to Dr. Balaji's presentation?
ma'am, this is Dr. Revati. I'm the moderator for this presentation on breast, ma'am, from Balaji Medical College. Am I audible?
Have you been able to reconnect?
Hello.
Yes, ma'am. You are audible, ma'am. Maybe you can summarize the case, ma'am.
Dr. Revati?
Yeah, hello. Am I audible?
Yeah, you're audible.
Yeah, ma'am, the idea behind presenting is this case is breast is actually a recognized entity in adults, but it's still rare in children. However, it can still happen. So the MRI is what MRI is the diagnostic modality of choice, and that is what makes it stand apart from other causes. Hypertension is the commonest etiology, and if breast is recognized early and treated appropriately, the outcomes can be really good. So that is the idea behind present this case, is to create an awareness that it can still happen in children. I thank IAP Chengai chapter of City Pediatric Meet for giving us this opportunity. I'm sorry for the connectivity issues that we are facing today, ma'am.
Anyway, it was a very good presentation covered with, and I think you have rightly stressed upon the fact that identified early has a very good outcome. It can be treated well. Thank you very much for the presentation.
Thank you, ma'am. Thank you
Moving
so
on
much.
to the next topic. Can I invite Dr. Balaji? Professor is in charge of pediatric endocrinology clinic from Vistara. He has endocrine first to share with us. Over to Dr. Balaji.
Thank you, ma'am. Ma'am, before that, actually, Dr. Vidya, ma'am, we actually called her. She is in nephrology. So, to give some points.
Yes. So, good afternoon, sir. Am I audible, sir?
Yes, yes.
Yeah. First of all, I'd like to my sincere thanks to Dr. Subhashar HOD and the whole department of SRM for giving me this opportunity. It was a very good presentation. So just few points I need to add up on this. Like the first thing, the child was seen in an OPD, and the BP check is very important. And whenever a child is presenting to you with some edema, so if that would have been diagnosed earlier, this complications of hypertensive changes would have been like we could have bypassed it. And that's a very important thing we need to learn from this. And the other things is management of hypertension. We may think like PSG and it's little like a easier thing we can just manage, but the hypertension management, very small fluctuations also can cause like severe seizures. That has to be like properly we have to titrate how much we have to like reduce all those things we have to monitor, and we have to titrate we have to give antihypertensives if needed. We should not hesitate to hike upon antihypertensives. We can come down anytime. So two or some many of the children may require two or three antihypertensive drugs also. And any child like this PSG and the press, it's actually we need not even follow with the MRI. Once like it is diagnosed once with antihypertensives, like the hypertension is controlled, the changes also would have disappeared. So it is not like whether should we repeat an MRI, nothing is like that, it's not needed. And the child has to be followed after 8 weeks or 8 to 12 weeks with a repeat C3 level. That's the most important thing that we have to do. If the C3 is low, we have to refer the child to a nephrologist. Child may require a biopsy. So these are the basic things we need to know when we manage a child with a PSGN. So it's a very nicely managed in this child. It's a very good presentation. So thank you.
Actually, I have one question, ma'am. Usually the blood pressure is high. It's, for this child, it was around 200. When we use an oral amphetamine, will it not
ரேவதி
drastically
ஆன்சர் பண்ண சொல்லுமா?
should we go
ரேவதியை
for
வெளியே போய் ஆன்சர் பண்ண சொல்லுமா? ரேவதி கிட்ட போய் ஃபோன் பண்ணி அது
Hello,
எடுக்க
sir.
சொல்லு.
It's not clear, sir. Like what you're asking, I'm not able to get the question, sir.
ma'am audible, ma'am?
Is it? It's audible now, sir. Just can you repeat the question, sir? Sorry, sir.
Yeah, we are giving nifedipine, right? Oral nifedipine. Yeah, should we go for some infusion based so that the blood
Sir,
pressure go?
definitely, sir. This child and this with the higher, we can have a controllable BP control, sir. Most of the time, oral, sublingual, nifedipine, and all can suddenly decrease the blood pressure, which we don't want to happen. So, it's ideally better to give a labetalol or sodium nitroprusside infusion. That will be the best thing in managing such hypertensive emergencies. So, that will be the most advisable thing, sir. Yes, sir. Yes, sir. Okay, sir. Thank you.
I will take just 2 or 3 minutes time. Okay. So that's part of the second series endocrine our endocrine team about stress dosing in children. So here are two scenarios. A 5-year-old boy with fetal adrenal hyperplasia on maintenance hydrocortisone presented with varicella and shock. So despite fluid resuscitation, he didn't improve and succumbed. So that is the first scenario. Congenital adrenal hyperplasia on hydrocortisone developed a varicella infection and worsened. So for the shock, they give fluid resuscitation, but still he didn't improve. And when we received, it was too late. He succumbed. And here is another scenario. It's possible a child treated on nephrotic syndrome with steroids. The routine 6 weeks we give an alternate day therapy. Presented 6 months later with vomiting, diarrhea, and shock. So this is just to sensitize that adrenal insufficiency and adrenal suppression should be suspected in scenarios where steroid is going on and stress dose should be given in these scenarios, or it can result in catastrophic things. So, what are the principles of HPA axis suppression? So, less than 2 weeks of steroids, maybe we can abruptly stop steroids, not an issue. 2 to 4 weeks of steroids, we can wean it over a period of week. But if the child is on 4 weeks of steroids, it's better to gradually taper. As per in nephrotic syndrome, also we go for alternate day therapy for 6 weeks, and then only we move on. So gradual tapering is important. But still, even in these scenarios where we have been giving for 4 weeks of steroid, as long as child is normal, fine. But there, when it comes to infection or surgery, some may not be able to respond properly to that stress, even up to 6 to 12 months of withdrawal of steroids. So even after 1 year of withdrawal, still some children may have certain features of adrenal insufficiency. So who needs stress dosing? So we all know that any child with congenital adrenal hyperplasia or Addison's, they definitely need stress dosing during infection. Also, someone who is on prolonged steroid therapy. This is the one which we need to be alert about. Someone who is on more than 4 weeks of therapy, some literature say even 2 weeks of therapy. For the next 1 year, we need to be a bit alert. If the child presents with inappropriately sick for any even trivial diarrhea, if the child is shocked, I think steroid insufficiency should be thought of. So, what are the situations? Any child with fever, diarrhea, vomiting, posted for surgery, major trauma or illness, or severe illness like sepsis, DKA. But it doesn't mean that for any exam stress and all, we need not give, it's not real stress. So we need to think about stress dosing. So, how we are going to go about the stress dosing? So, this is the last slide. So, usual maintenance is around 10 milligram per meter square per day. So, we have to give at least 3 times in the case of illness. So, for minor stress, if it is just a URI, low grade fever, we need not increase the dose, we need not give stress dosing. But if the fever is more than 38, pneumonia is there, gastroenteritis is there, minor procedure we are giving, we have to give at least 3 times the maintenance dose. It will come to around 30 milligram per meter square per day. If it is moderate illness, the child is having vomiting and decreased intake, then at least 50 mg per meter square per day, we have to give stress dosing. And we have to continue it till the child recovers from the illness. And for severe illness, for surgery, sepsis, and meningitis, a higher dose up to 100 milligram per meter square should be given, followed by 6th hourly we have to give, or you can even give as an infusion if it is the hospital setting. So this is the ultimate take-home point. So you have to suspect adrenal insufficiency in any child who has received steroids in the last 1 year period, and child appears sick, child is in shock, or uh, child is inappropriate for the illness, child is sick, sugars are low. So for the mild illness, you can just give 3 times the dose, it is 30 milligram per meter square per day. For moderate, it is 50 milligram per meter square per day of hydrocortisone, IM you can give. For any child who you have posted for surgery or child is in sepsis or meningitis, it has to be 100 milligram per meter square 6th hour. Thank you.
Thank you, Marjorie. Something very pertinent, I think. Giving us adequate stress, what are the indications, again, very relevant to all of us, which all of us learn something very good.
Thank you.
Moving on to the next presentation, I invite Dr. Abhinavani from SR Medical College to talk on feeding is in the fits, investigating metabolic cause of failure to function in young children. Over to Dr. Abhinavani.
My topic is feeding is in the fits, investigating metabolic causes of failure to thrive in an egg exam. So the objectives are approach to failure to thrive in egg exam, interpreting failure tests in failure to thrive, management of
Your voice is not audible. Next.
refers to failure to gain weight or change in weight of person and weight and loss of
Could you please increase the volume? Your voice is inaudible.
failure to thrive refers to weight less than third centimeter of his length and failure to gain weight over time or change in rate of growth such that weight for age or weight for length or height has crossed two major centers. The causes of failure to thrive is classified into organic and non-organic causes. Organic causes including GI causes such as PERD, malabsorption, IBD, and pyrostenosis. Neurological causes like attention deficiency, cerebral palsy. Renal causes like rheumatoid arthritis, cardiopulmonary causes like congenital heart disease, cystic fibrosis, and asthma. Diabetes, chronic parasitic
Dr. Abhinami, sorry, your voice is not audible.
and audible, sir.
No, it's not audible. It's very low.
Sir, am I audible now, sir? Am I audible, sir? Audible now, sir? Sir, am I audible?
You're audible, but you're echoing actually.
Connected outlet.
Am I audible, sir?
Yeah, you're audible.
Okay. So failure to thrive refers to weight less than third or fifth centile, failure to gain weight over time, or change in rate of growth such that weight for age or weight for length or height has crossed two major centiles. So causes of failure to thrive is classified as organic and non-organic causes. Organic causes include GI causes such as GERD, malabsorption, IBD, and pyloric stenosis. Neurological causes like intellectual disability, cerebral palsy. Renal causes like renal tubular acidosis. Cardiopulmonary causes like congenital heart disease, cystic fibrosis, and asthma. Endocrine causes like hypothyroidism and diabetes mellitus. Infections like chronic parasitic infections of the GI tract, tuberculosis, and HIV. Genetic causes like inborn error of metabolism, chromosomal abnormalities, miscellaneous causes like lead poisoning and malignancy. So non-organic causes include poverty, lack of knowledge, lack of breastfeeding, diluted formula feeding, and dysfunctional parent-child relation. So here is a 2-month-old female child with corrected gestation age of 20 days, brought with history of cough and breathing difficulty for 2 days, history of poor feeding and lethargy for 1 day, history of vomiting 1 episode, bilious in nature, non-blood state, no history of fever or cry during micturition, no history of polyuria, loose stools, or seizures. So these are the antenatal history. 23-year-old Yashoda with obstetric score of P3, L2, and D1, booked and immunized. Antenatal scans are normal with EDD 5/4/2025. Had a preterm LSCS due to previous LSCS in labor. Blood group was O positive. So, family history, third order child of third degree consanguineous parents with previous sibling death. Sibling death at 3 months of age. Child developed cough and fever, died due to unknown cause at day 4 of hospital stay. History of sibling death in paternal side present. So, past history, history of failure to gain adequate weight present during previous visit. Hence, trial of formula feeds was started 1 week back before admission. Treatment history, initially treated for current illness with oral antibiotics and nebulization in outside hospital for 2 days. Birth history, child is a late preterm, 34 weeks plus 6 days, AGA, girl, low birth weight with birth weight of 2.350. History of NICU stay in view of neonatal hyperbilirubinemia for 2 days. Child was vaccinated up to 45 days according to NIS. So on examination, child was lethargic, drowsy, plagiocephaly was present with signs of dehydration such as wide open and depressed anterior fontanelle, sunken eyes, dry oral mucosa, skin tugger goes back slowly, and cold peripheries was present. So anthropometry at birth, the child weight was between 10 to 50th centile. On during admission, it was less than third centile. Whereas length was between 10 to 50 centile at birth, whereas during admission it was 50th to 90th centile, and head circumference was 10 centile at birth and was at third to centile during admission. So vitals, heart rate was 140 per minute, RR was 64 per minute, and the saturation was 95% in room air, BP was 80/50. So these are the comparison growth charts between at birth and on admission. At birth, the child's weight was between 10th to 50th centile, and during admission, it was become less than third centile. So systemic examination, cardiovascular system, S1, S2 present, no murmur. Respiratory system, bilateral non-vesicular breath sounds present, no added sounds, no retractions. Abdomen, soft bowel sounds present. Central nervous system, child was lethargic with depressed anterior fontanelle, poor feeding and sucking. Tone was normal, and other primitive reflexes was normal. So these are the blood gas analysis. On admission, the pH was low with low PCO2, low PO2, and low potassium with increased chloride and decreased bicarbonate. Lactic acid was normal, anion gap was normal, showing normal anion gap, hyperchloremic metabolic acidosis. Whereas at 12 hours of admission, the pH was low and PCO2 was high with low potassium and increased chloride and low bicarbonate with normal anion gap, showing mixed acidosis. So, based on history and examination with the dehydration size, we initially suspected sepsis, probably due to community-acquired pneumonia or bronchiolitis or UTI. Since there was a failure to thrive with previous sibling death, we also suspected immunodeficiency disorders, inherited disorders, and inborn error of metabolism. So these are the causes of normal anion gap metabolic acidosis, which results from loss of bicarbonate or external acid infusion and is manifested by a low bicarbonate and normal anion gap. So causes include renal tubular acidosis, loss of
bicarbonate via GI and renal losses. Example, diarrhea. Compensation for respiratory alkalosis, carbonic anhydrase inhibitors usage, such as acetazolamide, urethral diversion, that is uretrosigmoidostomy, and other causes like hyperalimentation, that is TPN. So these are the basic lab investigations showing CBC showing anemia, leukocytosis with thrombocytosis, and RFT, LFT was normal, culture was normal, serum electrolytes showing low bicarb and potassium with increased chloride. Urine PCR was elevated, suggesting increased proteinuria, and urine pH was elevated, more than 7.5. CSF analysis was normal. So we have these are the differential diagnoses we initially had. Since the child had failure to thrive at the dehydration, we suspected feeding issues, which was ruled out since the child had normal feeding and was already on trial of formula feeds. Since the child had failure to thrive with poor feeding, lethargy, and tachypnea, we suspected sepsis, which was ruled out since child had no fever with the normal CSF analysis, culture, chest X-ray, USG abdomen. Since the child had failure to thrive and consanguineous parents, we initially suspected neurological causes, which was ruled out since the child had normal tone and other reflexes was normal. Since the child had failure to thrive with poor feeding and lethargy, we suspected endocrine causes, which was ruled out since the child had normal TFT and blood glucose level. Since the child had failure to thrive with previous sibling death, we suspected inborn error of metabolism, which was ruled out since the child had normal serum ammonia. Since the child had failure to thrive, we also had a suspicion of cardiovascular diseases, which was ruled out since the child had normal echovalvular findings with normal forelimb saturation. So further course in the hospital, since initially the suspecting sepsis and dehydration, we started on a bolus of RL 40 ml per kg IV antibiotics OT, and we O2, and we managed symptomatically. From 8 hours of admission, started on IV bicarbonate and IV potassium in separate line, central and peripheral line. At 12 hours of admission, child developed apnea following seizures. Hence, the baby was intubated, and echo showing poor cardiac function with ejection fraction of 35%. Hence, inotropes was initiated. From day 2, feeding oral bicarbonate and oral potassium was initiated. On day 5, since culture was sterile, IV antibiotics was stopped. Full feeds reached with oral bicarbonate and oral potassium. In view of normal iron gap, severe metabolic acidosis with failure to thrive, proteinuria, and increased urinary pH, baby was suspected for renal tubular acidosis. After evaluation was done, suspecting cystinosis and Fanconi syndrome showing megalocornea. USG abdomen was normal, genetic test done, and the whole exome sequencing report was awaited. On day 9, baby was discharged with oral bicarbonate at 12 milliequivalents per kg per day and oral potassium at 6 milliequivalents per kg per day. So this is the picture of megalocornea. So on follow-up, whole exome sequencing showed renal tubular acidosis. Baby's weight gain was adequate, and serum electrolytes was within normal limits. Repeat USG abdomen was normal. Hearing evaluation at birth and on follow-up was normal. So these are the electrolytes reports on follow-up. Initially, at 15 days of discharge, we tapered the dose to, since electrolytes has become normal, we tapered the dose of oral bicarbonate and potassium to 8 milliequivalents per kg per day and 5 milliequivalents per kg per day. 1 month later, after West report, we further tapered the dose of oral bicarbonate and potassium to 5 milliequivalents per kg per day and 3 milliequivalents per kg per day. This is the weight gain of the child on follow-up. Currently, the child is weight of the child is between 10 to 50th centile. Initially, it was between less than 3rd centile during admission. So this is the genetic report showing distal renal tubular acidosis with or without sensory neural hearing loss. So diagnosis, distal renal tubular acidosis. So renal tubular acidosis is a group of renal tubular disorders characterized by normal anion gap metabolic acidosis, presence with relatively preserved glomerular filtration function. It is of 4 types. Type 1, distal RTA due to reduced secretion of hydrogen ions through distal convoluted tubule. Type 2, proximal RTA due to reduced bicarbonate reabsorption from proximal tubule. Type 3, due to combination of proximal and distal RTA. And type 4, hyperkalemic RTA due to mineralocorticoid deficiency or resistance to mineralocorticoid. So these are the causes of RTA. Distal RTA due to primary and secondary causes, primarily due to your genetic abnormality, and secondary due to autoimmune hypercalciuric conditions, drugs, and tubulointerstitial nephritis and miscellaneous causes. Whereas proximal RTA, it is usually isolated RTA without Fanconi or generalized RTA, part of Fanconi syndrome. Whereas hyperkalemic RTA, it is due to mineralocorticoid deficiency, which is primary or secondary form, or mineralocorticoid resistance due to pseudo-hypoaldosteronism. So this is the approach to renal tubular acidosis. Whenever there is hyperchloremic metabolic acidosis with normal anion gap, look for urine anion gap. If it is negative, it is due to gastrointestinal losses or acid intake. When it is positive, consider renal tubular acidosis. Further, look for urine pH and serum potassium and bicarbonate levels. If the urine pH is less than 5.5 with the serum low or normal serum potassium, then it is proximal RTA to screen for other proximal tubular defects. If the urine pH is more than 5.5 with low or normal serum potassium, it is classic type 1 RTA or distal RTA. Screen for hypercalciuria, nephrocalcinosis, hearing and dental evaluation. If the urinary pH is variable between less than 5.5 or more than 5.5 with high or normal serum potassium, then it is type 4 RTA to look for renal parenchymal disease, transient potassium gradient and aldosterone levels. So these are the comparison points between proximal distal and hyperkalemic RTA. In proximal RTA, the potassium will be low with normal anion gap metabolic acidosis with urinary pH of less than 5.5 with negative urinary net charge and 10 to 15% of fractional bicarbonate excretion with normal urinary blood pressure CO2, and it is usually least responsive to therapy, usually associated with Fanconi anemia. Distal RTA with presence with low plasma potassium with normal anion gap metabolic acidosis with urinary pH of more than 5.5, positive urinary net charge, 2 to 5% of fractional bicarbonate excretion with low urinary blood pressure CO2, usually well responsive to therapy and associated with nephrocalcinosis and hyperglobinemia. Hyperkalemic RTA presents with high plasma potassium with normal anion gap metabolic acidosis with variable urinary pH and positive urinary net charge, 5 to 10% of percentage of fractional bicarbonate excretion with low urinary blood pressure CO2, usually responds to therapy and associated with renal insufficiency. So management, the mainstay of management is bicarbonate replacement. In proximal RTA, usually supplement with 15 to 20 milliequivalents per kg per day in oral sodium bicarbonate or sodium citrate. Distal RTA, 2 to 4 milliequivalents per kg per day. Additional therapies including, if it is associated with Fanconi syndrome, phosphate supplementation, hypercalciuria, to use thiazide diuretics, type 4 RTA, to use sodium potassium exchange resins such as sodium polystyrene sulfonate, orthopedic intervention for involvement of bone, definitive management for any obstructive uropathy. So drugs commonly used in RTA, these are the drugs commonly used in RTA: sodamine, portrate, syrup nodosis, Scholl solution, Joule solution in case of proximal RTA, and adpos sachet. So long-term complications and prognosis. Patients of distal RTA may develop hypercalciuria, usually presents as gross hematuria, hence should be monitored regularly. Nephrocalcinosis or nephrolithiasis requiring thiazide diuretics to decrease urinary calcium excretion. In type 4 RTA may require chronic treatment for hyperkalemia. Patients with systemic illness and Fanconi syndrome may have growth failure and rickets. Patients with proper treatment generally demonstrate improvement in growth. So take-home message: whenever a child is presenting with failure to thrive, renal tubular acidosis to be ruled out, and early diagnosis of distal RTA can prevent lifelong complications, especially growth and bone abnormalities. Normal anion gap metabolic acidosis, RTA to be ruled out. Thank you.
I think Chief Secretary was very well. Again, emphasizing the role technologies play in diagnosis. Nowadays, whole exome sequencing, next generation sequencing are available quite speedily, and hence helps us also quite often in arriving at the diagnosis. I just have one question to ask. Did you do urine pH, specific gravity and osmolality?
Sorry, ma'am, can you?
Dr. Abhinandan, are you there?
Yes, ma'am.
Did you do urine pH? Urine specific gravity, urine
Yeah, urine pH.
Possible and
Urine pH was 5.5 in this specimen. That was consistent with RTA. But on admission, he had seizures also. So with some abnormal eyes and eyelid congestions and all was there. So we thought whether it could be proximal RTA. But and he had a urine of proteinuria also. So it was a confusion whether it could be proximal or distal RTA. But urine pH was consistent with the distal RTA only, ma'am. Am I audible, ma'am?
Sir, your voice is not clear, sir. Very loud. Can
Yes, sir.
you start from-
Speak. Hello? Yes, sir.
Yes, sir, now fine, sir. Please.
The initial pH, urine pH was 5.5, sir. More than 5.5. And baby had a massive proteinuria. That was in nephrotic range, sir. And baby's eyelids and all. So initially, we had some edema, and we thought whether it could be cystinosis considering previous sibling death. And baby had seizures also at 12 hours of admission. So with neurological involvement, we thought it could be proximal RTA. So we sent the genetic testing and urine bicarb measurement that was not available in our lab, and neighboring lab also we tried because anaerobic containers were not available. We were not able to process the urine bicarb and urine CO2 levels, sir. So only we sent genetic testing. Finally, if suspecting proximal RTA at discharge, we supplemented high dose of bicarb and potassium. But after genetic testing report, we titrated the dose of bicarb to the therapy for distal RTA, sir. Yes, sir.
Proving my point on the importance of or the impact of whole exome sequencing in our diagnosis. Anyways,
Yeah.
thank you for worked up the case very well. How is the check doing at present?
Baby presently is fine, ma'am. Baby is almost reached 5 kgs now. And only any intracurrent illness, maybe the previous also the intracurrent illness, baby had some respiratory infection that has triggered this episode of crisis. So maybe, can I ask Dr. Vidya, madam, sir, to
Yeah.
Dr. Vidya, ma'am,
Yes.
can I ask
Yes.
you, ma'am,
Yes.
to any
Yes.
update on this renal tubular acidosis? Yes, ma'am.
Sir, yes, sir. Like, first of all, like the case is like very well managed, sir. Because like when usually we follow the childrens with the renal tubular acidosis, when they are falling in the growth curve, that's the most happiest thing we will actually see. Because every time, like whatever maybe the supplements we give, to reach them in the growth curve is will be the most challenging thing. So this child is like the key thing is the child is diagnosed earlier and managed very effectively, sir. That is whatever maybe the diagnosis proximal or distal, the management is going to be the replacement whatever it is the child is losing. So the most important thing is the child has been managed very well with all the supplements. And as with growth, when they are growing, the supplements, the requirement also will gradually decrease. We may not need to give the very high doses of potassium and bicarbonate, sir. That's one thing. And did we do a urine calcium creatinine ratio, sir? Like that will also will be very useful for follow up, sir. Like whether it was done, sir, like calcium creatinine. Uh,
We did that FENA we estimated, ma'am, sodium. Maybe
yeah.
we did not do calcium creatine.
Yes, sir.
Yeah,
Yes, sir.
yeah.
Because like yeah, we
Ultrasound
can do it in the
abdomen did not show
yeah,
any renal
yeah.
calcification, ma'am.
Yes, sir.
Yeah. So and hearing also we repeated because that gene mutation was like it can be associated with hearing loss. So we did a
Yes, sir.
repeat on the follow up also, and in both the time the initial newborn screening OAE and on follow up AABR both were baby was pass only. So that was good thing for
Yes.
the baby, ma'am.
Yes, sir. Yes, sir. This calcium, like we can even follow up in the because like before the nephrocalcinosis develops, the earlier features will be like hypercalciuria, sir. If it is picked up early and like followed up, that we can still do in the follow up, sir, because we don't want the nephrocalcinosis to develop, sir. So that has to be in the surveillance, that has to be monitored, sir. And everything else was like fine, sir. Like we have like it was well managed, and the urine pH is the most important. Like still we tell like with other investigations are still it is coming, we can still clinically like differentiate. So the urine pH is the most important thing that is consistent here. We have got a urine pH of 7.5. That's like a very good value that tells the distal acidification is affected, sir. That is the reason we are getting an alkaline pH. So that is an important test that is added up, and everything was very well evaluated and followed up, sir. So we can just follow up a urine calcium in the future. And the proteinuria, I just discussed with Dr. Abhirami also, sir. Most of the time, when we go with the urine protein creatinine ratio, sometimes the creatinine in the urine will be very less, sir. As in the case, they have given something like a 3. So we should at least have a creatinine of some 15 to 20 to interpret the protein value. Like if the urine creatinine is very less, we can falsely will get a high proteins or urinary protein creatinine. So we can like the normal urine protein will give a very good idea, sir. Like if it is mostly we'll expect 1 plus or 2 plus, we don't see a nephrotic range protein in this in a tubulopathies basically, sir. So that maybe would have confused in this case, I feel, sir. So like maybe that value would have been like overestimated, and that would have confused with the diagnosis of proximal and distal, sir. So it's everything like all of the things are very good, and happy that the child is doing well, sir.
Thank
Yes,
you,
sir.
ma'am.
Yes, sir. Thank you, sir.
So congratulations to the team on case well managed. Moving on to the ultimate presentation of the day, I invite Dr. Gokila from Kamachi Memorial Hospital. She is going to discuss untangling the molecular history of the childhood cancer. Dr. Gokila, please.
Yes, ma'am. Good afternoon, ma'am.
Yeah.
Ma'am, am I audible, ma'am?
Yeah, like audible. I can proceed with the presentation.
Ma'am, can you see my screen, ma'am?
Yeah, yeah. Screen is visible. Maybe this is yeah.
Okay. 1 minute. In this screen. Good afternoon, one and all. I am Dr. Gokila, second year DNB resident from Kamakshi Memorial Hospital. Today I am here to present an interesting case untangling the molecular mystery of a child with cataract. Our clinical lead is Dr. Rajeshwari ma'am, Chief Consultant, Developmental Neurologist, Clinical Geneticist, Division of Medical Genetics. I thank Rajeshwari ma'am to give me an opportunity to present this case before this august audience. Background. A 15-year-old girl with congenital ichthyosis and bilateral cataract operated in the year 2013 was under evaluation for the above clinical condition in Ophthalmology Institute outside. In suspicion of glycosylation disorder, whole exome sequencing was done. No pathogenic variant or likely pathogenic variant causative of the reported phenotype was detected. In spite of this, in view of strong suspicion of genetic disorder, child was referred to Genetic Division, Department of Pediatrics, Dr. Kamakshi Memorial Hospital. And what's the genetic report? There was no pathogenic variant reported for the glycosylation disorder, but there was 2 additional significant variants reported which may not directly relevant to the phenotype. The variants were present in the gene EBP and PGM1. With this background, in order to know what is the significance of additional variant, we started evaluating the child. Coming to the antenatal history, the child was first child born out of non-consanguineous marriage, spontaneous conception, antenatal scans were normal, there was no comorbidities in mother. She was a term child born by delivered by LSCS, was appropriate for gestational age, cried immediately after birth, breastfed on day 1 of life, and the child was noted to have congenital ichthyosis. Postnatal history, there was no NICU admission, no neonatal seizures, no neonatal hyperbilirubinemia, no neonatal hypoglycemia. Development history. She attained head control at 5 months of age. She sat alone at 8 months. She walked alone at 1 year, 6 months of age. Called mother as Amma at 11 months. Two-word sentence at 2 years. Now the child is studying in class 10 CBSE syllabus, average scholastic performance. From the development history, we were able to know the child had mild motor delay. Past history, at 3 years of age, mother noticed squint in the child. Evaluated and found to have bilateral cataract. Bilateral cataract was operated at 3 years of age. Child is presently having pseudophakia and on spectacles now. At 7 years of age, she was investigated for mild malabsorption, hair loss. Colonoscopy was done, which revealed non-specific colitis. In view of child having cataract, congenital ichthyosis with mild malabsorption, she was suggested genetic testing to rule out any glycosylation disorder. On inquiring any further complaints, mother informed, my child is not growing tall, but her feet is growing fast. She frequently had to change her footwear size. This is the family pedigree of the child. The child was born out of non-consanguineous marriage and first child. And the genetic testing reports were genetic test done to rule out glycosylation disorder, which reported no pathogenic variant causative of glycosylation disorder. There was additional 2 variant reported in the genetic test report. The variants were a likely pathogenic variant in PGM1 gene, which was heterozygous, which can cause congenital disorders of glycosylation in autosomal recessive inheritance. Since the child is heterozygous, she is only the carrier of the disease, and this disorder cannot be the a reason for the phenotype of the child. And we had another interesting variant, which is pathogenic variant in EBP gene, which is inherited as an X-linked dominant disorder as chondrodysplasia punctata. The child had a heterozygous variant in EBP gene, which could be the reason for the phenotype of the child presented. With this background and genetic report, the child came here for the reason why she had all these problems. So we reverse phenotype the child. We went for deep phenotyping of the child. On deep phenotyping, from head to toe examination, we found child had broad forehead, seborrheic dermatitis in scalp, coarse hair, patchy alopecia, microphthalmia, microcornea, cataract operated with intraocular lens, ichthyosis, scaly skin, orthodontic treatment for dental malalignment, flat foot, and foot was aborted. And vital signs, her vital signs were stable. Anthropometry showed minus 2.20 standard deviation of height, and systemic examination were normal. So from the anthropometry, we were able to find that the child is short. The child had short stature. So to summarize, we had a 15-year-old girl who had bilateral cataract, congenital ichthyosis, microphthalmia, microcornea, coarse hair with patchy alopecia, short stature, skeletal features. All these phenotypes point to the diagnosis of chondrodysplasia punctata, which she carries a gene also. On further investigation, the child had 25-hydroxy vitamin D insufficient range 18.11. Otherwise, the blood investigations were normal. On having a diagnosis of chondrodysplasia in hand, we want to evaluate further and prove that the phenotype is due to the genetic variation in the EPP gene. We went for skeletal survey. From the skeletal survey, we found that child had scoliosis. This X-ray shows scoliosis of lumbar vertebra. And there was a shortening of bilateral femoral neck, which results the short stature of the child, which could be the reason which is causing rhizomelic short stature. And the X-ray of hand and foot were normal, except for a mild malalignment of metatarsal bone in the foot. This X-ray shows the acromelic growth of the child is normal, whereas the rhizomelic growth, femur is shortened. MRI spine showed thoracic scoliosis, upper thoracic kyphosis, multiple level of end plate deformities with disc height reduction. So, chondrodysplasia punctata has a specific biomarker which is 8,9-cholestanol. Chondrodysplasia punctata is an X-linked dominant disorder which is due to mutation of EBP gene, which encodes for an enzyme called 3-beta-hydroxysteroid delta 8 delta 7 isomerase, which is involved in the cholesterol biosynthesis, in the distal cholesterol biosynthesis. If the enzyme is deficient, there is accumulation of 8,9-cholestanol and 8-dehydrocholesterol in the plasma of the child. So there is a specific biomarker for chondrodysplasia punctata which is found in this child. 8,9-cholestanol is detected in the plasma of this child. This 8,9-cholestanol is normally not found in the normal patients. So this is a specific biomarker of chondrodysplasia punctata, which is detected in this child, proving the diagnosis. And the genetic testing, which we had already reported, we went for Sanger validation and segregation of the variant in the EBP gene. This variant was not present in the parents of the proband. The reported variant is a de novo variant in the proband, thus confirming the diagnosis of X-linked dominant chondrodysplasia punctata, Conradi-Hunerman-Happel syndrome. What is chondrodysplasia punctata? Chondrodysplasia punctata is a group of inherited disorder that affects skeletal system, eyes, skin, brain. Presents with vast phenotypic and genotypic heterogeneity. Classification is based on Mendelian inheritance. The chondrodysplasia can be inherited as autosomal recessive, autosomal dominant, X-linked dominant, and X-linked recessive. One of the main DD of X-linked dominant chondrodysplasia punctata is rhizomelic form, which is inherited as autosomal recessive form, which is a peroxisomal disorder. Coming to our child, we have chondrodysplasia punctata X-linked dominant, which is due to EBP gene mutation, deficiency of delta 8 delta 7 sterol isomerase and hemopamil binding protein. Affected females have elevated 8-9 cholesterol and 8-dehydrocholesterol. X-linked chondrodysplasia punctata is disorder caused by mutation in hemopamil binding protein encoding for an enzyme 3-beta hydroxysteroid delta 8 delta 7 isomerase involved in cholesterol biosynthesis. EBP is involved in conversion of lanosterol to cholesterol, a vital component of cell membrane, which is precursor for the synthesis of steroid hormones, bile acids, and vitamin D. The enzyme mutation disrupts the enzyme function, leading to a variety of clinical manifestations like short stature, stippled epiphysis, cataract, ichthyosiform erythroderma, patchy alopecia. Unclinical features of chondrodysplasia punctata is growth deficiency, short stature, craniofacial findings like frontal bossing, depressed nasal bridge, sparse eyebrows, eyelashes. Skeletal manifestations are stippling calcification involving epiphysis of long bones and vertebra, trachea and distal end of ribs, rhizomelic shortening of limbs, often asymmetric, scoliosis, postaxial polydactyly. Abnormality of skin, hairs and nails or scaling ichthyosis in the newborn period, which usually resolves in first month of life. Linear whorled atrophic patches involving hair follicles, which is follicular atropoderma. Coarse scalp hair with scarring alopecia. Flattened split nails. Ocular anomaly, cataract, which can be congenital, which can be asymmetric or sectorial. Microphthalmia and microcornea. In our child, we had all these phenotypes. The child had short stature, rhizomelic shortening of limbs, scaling ichthyosis in the newborn period, coarse scalp hair with scarring alopecia, cataract which was operated, and she had microphthalmia, microcornea with skeletal features. So, radiographic investigations of chondrodysplasia punctata can show rhizomelia, punctate stippling calcification, scoliosis, vertebral anomalies. Specific biochemical marker is plasma 8-9 cholesterol and plasma 8-dehydrocholesterol. And molecular genetic testing is genetic mutation in EPP gene. And what is the treatment? Treatment should be symptomatic and individualized. Treatment is multidisciplinary. Orthopedic management for limb length discrepancy, assessment of kyphoscoliosis regularly, which may cause a restrictive lung disease in the later part of life. And for dermatologic manifestation, keratolytics, emollient, sun protection can be used. For ocular manifestation, if the child had cataract or vision abnormality, it should be corrected. And standard intervention for associated anomalies of hearings and hydronephrosis, etc., should be done. And regular surveillance should be done, and family support should be done, and genetic counseling should be done. Why genetic counseling is very important? Because it is inherited as X-linked dominant pattern. Women with an EBP germline pathogenic variant have 50% chance of transmitting the pathogenic variant to offspring in every pregnancy. EBP pathogenic variant in sons are usually lethal. Female proband had variable phenotypic expression because of skewing of X chromosome. Conclusion: chondrodysplasia punctata is an extremely heterogeneous disorder. Deep phenotyping and high index of suspicion is essential to diagnosis. Specific biomarkers of chondrodysplasia punctata X-linked dominant is increased plasma 8-10 cholesterol and 8-dehydrocholesterol. Heterozygous pathogenic variant in EBP gene is identified by molecular genetic testing. Treatment is individualized and symptomatic. Lifelong surveillance is mandatory. Genetic counseling and prenatal genetic testing is advised in female proband to prevent recurrence risk in subsequent generation. Thank you.
Again, I must congratulate Dr. Tina and her team. Because like you.
Sir, ma'am, good evening. This is Dr. Prahada, the moderator of the previous session. I have a few inputs, ma'am. Before that, is there any questions that I can take, ma'am?
I just would like to make a point here. Whenever we talk about conference space and computer, we always talk about this epiphyseal stippling that occurs. But if you talk to radiologists, most of them say that by 1 to 3 years, the stippling is no longer visible.
So, ma'am, this child came to us by 15 years, no, sir, ma'am. So,
probably that's the reason you did not.
Yeah, that's why we are not able to see. Because of epiphyses are fused, we will not be able to appreciate the stippling, no, ma'am.
Yes. So, an interesting way of working out the diagnosis. Please carry on with your comments.
Yeah, only we wanted to give importance to 2 points in this presentation, ma'am. One thing, when Kokila was presenting, she was saying that they suspected congenital disorders of glycosylation outside. This child was evaluated in various places outside, even went to a geneticist, mostly in an ophthalmological center because she had cataract and congenital ichthyosis. Of course, the malabsorption, they had done objective studies and it was proved colonoscopy, everything was normal. And when they suspected congenital disorders of glycosylation, as Kokila quoted, it is not true that there is no pathogenic variant. There was a pathogenic variant with congenital disorders of glycosylation. If you can see, it is in the PGM gene, ma'am. But only thing is, it's in a form of heterozygous autosomal recessive form, which means she cannot carry the disease because she's heterozygous and it is inherited autosomal recessively. So the geneticist outside was confused that the phenotype is matching with congenital disorders of glycosylation. There is a pathogenic variant in congenital disorders of glycosylation, but only thing is it's not disease causing because it is heterozygous in autosomal recessive state. He didn't had phenotype this child, ma'am, because he's not a clinical genetist. So he had referred to us. So the importance of clinical genetist comes to the point. Before that, the only 3 phenotypes they were looking upon was cataract, ichthyosis, malabsorption, delay, developmental delay. But when she came to us, the clinching point was a short stature. Though there was no obvious rhizomelic shortening, there were pointers to rhizomelic shortening in the child. So that's when we took the phenotype, when we reverse phenotyped or deep phenotyped, we were like, why can't counter dysplasia punctata, which is also another pathogenic variant, homozygous in an X-linked dominant state, might be the reason. So we just have to prove that it is probably that. And that's when when the deep phenotyping by a clinical genetist helps. Point number 2 is wherever it is possible, if you can read the previous reports, look into review of literature, look for biomarkers which are specific for one disease. It is easier to prove. That's why we came for the deoxycholesterol. Only the presence of it makes counter dysplasia punctata positive. Like it need not be in higher amounts and all. So that was a clinical benchmark which I think we got it only because we read through previous reports. We searched for particular biomarkers. So 2 things is clinical generalist definitely makes a great difference because this mother was so anxious, and at least at the age of 15 years, we were able to give her an answer for what is actually happening with her child and what she should, because she's a 15-year-old female, the mother wanted to know about her future life, like menarche and marriage and childbirth. So I think we actually helped her to get an answer. Probably not something she was looking for. But yeah, her options of, if she wants to do genetic counseling, she wants to undergo an IVF and all those stuff.
Yeah. So, congratulations to your team for having done a great job. Any questions from the forum?
Ma'am, we have orthopedician, ma'am.
Hello.
Yeah, good afternoon, ma'am. I'm Dr. Gautaman, pediatric orthopedician from SRM. So, as orthopedician for this child, 3 points I just want to enlighten. One is regarding the hip. It will go for varus deformity, coxa vara. So for that may require, am I audible, ma'am?
Yes, sir, you're audible.
Vera. So patient may require future osteotomic correction for the same. And as of now, is there any waddling gait for the child, ma'am? As of now,
No,
sir?
sir.
Or no.
Not that is very obvious. No,
Yeah,
sir.
not okay. I have just seen the X-ray where it shows the neck shaft angle is somewhat okay, not that much, very much reduced. And the second point is limb length discrepancies. The child height is 147, I think, 147 centimeter. And we can just wait for 1 or 2 more years. And if the height of the child is not very much not to that of our recommend, we may go for limb length correction. But the problem with this child is the healing after limb length surgeries, like if you put any X-fix like Ilizaro or other LRS like thing, the healing might be very much difficult. So if the child requires, we can go, or else it's better to leave the child for without any correction for the limb length discrepancy. And as of now, child is having test planus, flat foot. So it is recommended to give some footwear modification like medial arch footwear, so that the pain won't be there in the ankle region. So is the footwear modification done
Ma'am,
for the child?
she is in the sir. Sorry, she's in orthopedic follow-up outside, sir. This case was purely referred for a genetic answer
Okay.
to us.
Yeah, yeah.
They
Okay,
have
okay.
been mother is a very informed mother, so
Okay.
she is very good in following up stuff, sir. So, but here we were referred by a geneticist from outside only because they were not able to answer what and
Okay,
how
okay,
it
okay.
goes.
Okay, ma'am. Thank you, ma'am. Thank you.
Okay, sir.
Thank you, sir, for your input. If there are no more questions, I will. Any further discussion? If there are no more discussions, I think we can close this session. Over to Dr. Ramesh.
Thank you. As a part of those of the basic Chengai period, first and foremost, I express heartfelt gratitude of our chairperson of the Leadership for facing through this occasion. A sincere thank you for our presenters. A warm thank you to our moderators and panelists. I would also like to recognize the tireless efforts of our IEP Chengai community, Dr. Subhash sir, President, IEP sir, Vice President, Saudin sir, Secretary, Suresh Kumar sir, Treasurer, and then coordinator Dr. Balaji sir and convener Dr. Rashid sir. Thank you. And with all that, I actually conclude today's Chengai period. Thank you and have a wonderful evening.
So, would it be possible to summarize the slides that were left out at the presentation, sir? I understand that it's really late and I apologize for the inconvenience.
Hello.
Hello, ma'am.
Yeah, please go ahead.
Thank you so much, ma'am. So I would just like to emphasize on the reason why we presented this case. And I just go with a brief summary. Here we have the clinical picture of the child. It was a picture of acute glomerulonephritis with low serum C3 levels, with the presence of pyodermal skin infection and evidence of antecedent streptococcal infection by elevated ASO titer. In the background of this setting, the child developed headache, altered sensorium, and seizures. Actually, the child presented to us in a state of status epilepticus, where all the prior treatment was done in an outside clinic. So the presenting complaint to us was just seizures, with the background of these other underlying nephritic features. So with the high index of clinical suspicion of the possibility of posterior reversible encephalopathy syndrome, we proceeded to do an MRI which showed bilateral symmetrical vasogenic edema in the parieto-occipital lobes and TT flare hyperintensities in the basal ganglia. So this critical MRI finding with a clinical picture of encephalopathy in the background of hypertension with acute post-streptococcal glomerulonephritis led us to the diagnosis of posterior reversible encephalopathy syndrome. So I'd just like to highlight the MRI finding. Since PRESS is a clinical radiographical diagnosis, this is a gold standard investigation which came to our diagnosis. And we proceeded to manage the child symptomatically as hypertension control is the most immediate intervention, as PRESS is entirely reversible if the hypertension is corrected appropriately. It's really important to prevent cerebral hypoperfusion, so it's important to gradually reduce the blood pressure from 99 to 95th percentile over 48 hours, which is what we aimed to do. So we proceeded to do that with intravenous furosemide and oral nifedipine under the guidance of pediatric nephrologists. And the seizure control was also done with intravenous anti-epileptics, which was continued for 2 days and then for a week tapered and stopped with the help of pediatric nephrology. So we needed a multidisciplinary management for this. And the take-home message is that we saw that the child's sensorium normalized in 24 to 36 hours. The blood pressure returned to normotensive range over 5 days. Complement levels normalized within 2 weeks, which is the reason why we did not proceed with the biopsy, as the indication is to do a biopsy if the complement levels are elevated beyond. Gross hematuria resolved in 4 to 5 weeks, as well as gross hematuria. Microscopic hematuria resolved in 1 month. So on follow-up and monitoring, we found the resolution of all these symptoms as well as the resolution of medication. And the key take-home is that post-infection glomerulonephritis leading to stress in children is as rare as 0.04% to 5.2%. And we do not have enough data regarding the underlying risk factors and complications, as it is largely unrecognized and underreported. So a high index of suspicion is necessary for the diagnosis of posterior reversible encephalopathy syndrome. We need neuroimaging to confirm the diagnosis and need a multidisciplinary approach to ensure optimal outcome and to prevent neurological sequelae. So I'd just like to summarize the presentation in these 2 words. Really apologize for the inconvenience caused, and thank you so much for this opportunity to present on this platform, and to my guides and professors for guiding me in this presentation. Thank you so much.
Thank you, Dr. Roshni. We appreciate your enthusiasm. And if there are no more questions, we'll conclude the session. Thank you.
Thank you, ma'am.
Thank you. Thank you.